joining us on this last echo of the academic year. There'll be some new numbers in July, but kind of exciting to be wrapping this year up. And we have an amazing presentation from Dr. Haymon. And she even has a case vignette embedded in her presentation. Next slide, please. Yes, so if you're able to, we love, especially as we're doing a discussion, to see people on camera. Certainly, especially if there's more than one of you in the room, please let us know your name and your clinic so that we can give you the CME credit. And the usual mute your microphone when you're not speaking, and then when you unmute, help us to see where you are in the Hollywood squares by saying your name. Next slide. And for those of you at University of Washington, there is a number to text to get your CME credit and a code to text as well. And for everybody else, please, Sammy will help with getting your attendance for you, the free CME credit. And these are our accreditations, and each session is 1.25 free CME credits. And all financial mitigations have been, relationships have been mitigated. And there are a bunch of other ECHO series. We've talked about them before, but would like to continue to remind you of all the other opportunities to engage with Project ECHO, whether it's focused on geriatrics, TBI, addictions, or telebehavioral health training. And also there are telephone consultations available and a telepain series. There are University of Washington Neurology Grand Rounds. Archives are available, and also the Psychiatry Grand Rounds. Both of them really great to review or attend as your schedule allows. And last but not least, there is a weekend left to fill out this application for the BOLD grant opportunity. This is funding that we would love for people to be able to tap into. So please spread the word. It is due June 30th, and Samantha is available for any questions. We would love to have many more people join our network. And if there's any upcoming case presentations, our door is wide open. We would love to be able to learn from all of you and to have our community help improve the care of your patients. And yes, please, we love these discussions, but these are recorded and posted online. So please be careful about PHI. And we would also greatly appreciate a survey at the end so that we can continue to improve. This is our hub team. We are whittled down a bit today, but I think we'll be back in full force as the summer goes on. But this is our team here, multidisciplinary and also multi-site. And all of you stretching all across the state of Washington, and just so pleased that you continue to work with us. And without further ado, we have Dr. Carroll Haymon talking with us today about multicomplexity in patients with dementia, transition to a palliative care approach.
I'm targeting my talk today, really the primary sort of audience consistent with this, the goals of the ECHO program is really practicing primary care clinicians, but I would sort of broaden that to say like primary care clinicians and the people who love them, which is really kind of all of us. I think whether we're in primary care or not, a high functioning primary care system benefits all of us. Next slide, please. So we're talking today about multicomplexity in dementia, and sort of why did I use this kind of made up word multicomplexity, and what does that even mean? So just for a moment of explanation, you may well have heard of the 4Ms framework developed many years ago by IHI, just as a way to help guide us towards better care for older adults. the 4 M's are medications, mentation, mobility, and what matters. And in our geriatric fellowship and family medicine training, we do a lot of work around the 4 M's. The geriatricians, the American Geriatric Society, of which I'm proudly a member, couldn't leave well enough alone and added a 5th M, which was the M of multicomplexity. And people interpret multicomplexity different ways, but I really think it's a way to try to acknowledge the reality that older adult patients often have multiple intersecting chronic conditions that makes their care complicated. So multicomplexity, I really sort of think of also multimorbidity or multiple chronic conditions. Next slide. So today, what I really want to focus on is not so much managing dementia, which we've had a lot of teaching on in this session in other times, but really managing patients' other medical conditions in the setting of advancing dementia, or, really as a practicing primary care clinician, to what extent should the presence of dementia change how I'm thinking about my patients' diabetes, blood pressure, COPD, all their other chronic conditions? So we are, of course, going to touch a little bit on dementia management and on sort of palliative care for late stage dementia, but those are not the primary goals for today. And in fact, just to highlight, those have been covered well in other ECHO presentations. Next slide, please. So I'm really hoping that, by the end of today, people will feel comfortable recognizing signals that dementia is progressing in patients, and therefore we need to think a little bit differently about how to manage their other medical conditions, their multicomplexity, if you will, and also, learn some tactics for how to actually make that happen. So who am I and sort of why am I qualified to give this talk today? Like I said, family doctor, board certified geriatrician. I'm also boarded in hospice and palliative medicine. I'd say my main expertise here is more than 20 years of clinical practice experience as a primary care doctor. I've also done a lot of work in medical leadership with IORA, now owned by One Medical, now owned by Amazon. As well as a lot of teaching of trainees, residents, fellows. I'm lucky enough to have 2 of my current fellows on the call today. And I also have my own consulting business and work as a clinical advisor to healthcare companies. Among them is Ripple, and really trying to help. Sort of my frame is I'm really interested in helping clinicians in a lot of different settings be better at taking care of complex, frail older adults. And I've kind of dedicated my career to that work. Next slide. I have nothing to disclose. So multicomplexity or multimorbidity matters in patients with dementia because dementia patients have a lot of comorbidities, right? Sort of no news to anyone on this call, but this is some CMS data looking at Medicare beneficiaries with a bunch of chronic conditions. And you can see that in people who have Alzheimer's disease as a diagnosis, only 5% of them don't have any other chronic conditions. And more than half of them have 5 or more other chronic conditions. And so as a PCP, you're tasked with not just what are we going to do about the dementia, but also like, what are we going to do about all that other stuff and how do we keep it all in balance? And that's sort of what we're addressing today. Next slide. You may have seen this graphic before. It's a bit of a classic from the world of palliative care. The idea here is that when someone is given a diagnosis of a serious life-limiting illness, like dementia, at the beginning, the green arrow of diagnosis, initially the care of their conditions may be primarily curative or disease modifying, intended to prolong life. But then in an ideal world over time, we increase how much of their care is really palliative in nature or focused more towards comfort and improving the quality of their life. In dementia, that's a little bit there really isn't a lot to sort of modify the disease, so we take a palliative approach, from the outset, but I would encourage you to think about this model, again, not just for how we are treating their dementia, but for how we are thinking about all of their other chronic conditions. So, same idea, serious life-limiting illness, over time, can we shift more from a curative life prolonging approach to perhaps more of a comfort focused palliative approach. Next slide. So, in order to successfully manage multicomplexity and dementia, these are the things that have to happen. And this is kind of what we're going to go through over the next half hour or so. We need our patients and their families and care partners to really understand the natural history and the prognosis of dementia. They sort of need to know what to expect and how to prepare. And that really underlies, that's a necessary precursor to be able to talk meaningfully about changing how we're managing all their other medical stuff. We also need to understand, sorry, go back, please, Sammy. We also need to understand as clinicians a patient's stage of dementia and their approximate life expectancy to help us guide our patients in the decisions that we make together around how we're going to manage their other medical care. So we'll talk a little more about that. Also, of course, importantly, sort of basic primary care and palliative care skills around exploring goals and values. And then really our task is to help our patients and their families balance the benefits and the burdens of ongoing care. And often really helping, allowing and granting them permission to pull back on some of the medical things that may have been entirely appropriate even just a few years ago. And then, of course, to do this well, we need to be able to revisit it regularly over time. So, next slide. That's why I really sort of think of this most simply is that we're doing our jobs the best when we can help our patients see the forest through the trees. So we have all these trees, and in primary care, we got a lot of trees. If we think of all their chronic conditions, you got diabetes, tree, heart failure, tree, hypertension, tree, COPD, tree. And if we just manage one tree at a time, we're not really doing our patients a favor, right? So good primary care means we understand and see the forest, and we help guide care in that context. Next slide. I'll just note that I think some of the principles that I'm talking about today are not unfamiliar. And in fact, we in healthcare tend to be a little bit better at this in patients who have other serious life limiting illness, like perhaps an incurable cancer. We're a little better at saying early on, maybe we don't need to pursue screening. Maybe we don't need to be as aggressive about diabetes management in the face of another serious illness. And yet I would submit, in my experience, the healthcare system is we're not as good at that in dementia. And in fact, if we just assume as PCPs or as patients that other health, that other interventions are going to naturally fall off because a patient has dementia, that is not really what happens. So sometimes if we do nothing, the crank just keeps turning, the medical system crank, and we keep sort of doing things to patients even after it has much value. Next slide. So the first thing, sort of, again, a necessary precursor to having these conversations and guidance with patients and caregivers is the education, prognosis, and staging of dementia. So next slide. Really important to recognize for patients and families to understand basic dementia education, right? What do I expect and how do I prepare? And although we do a decent job trying to educate people about this in primary care, the thing I want to say is that there is a lot of community resource that is available, especially in the state of Washington. We're very fortunate here. There is a lot of community resources that are very helpful in educating people to do it. So the headline is, you don't have to do it all yourself. use the resources available in your community to help guide and educate your patients and families about what's going on and what to expect. So I just listed a few of them here, and these links are all live when you have access to the slides, which you will. Alzheimer's Association, AARP, are advocacy groups that have a lot of dementia education. If in the greater Seattle area is the Memory Hub, sponsored in part by UW, which is just a lovely resource for patients and families to learn more and get support. Every county has an area agency on aging, and many of them have dementia resources. And then shout out to the Dementia Roadmap, linked here, which is a product of the Washington Dementia Action Collaborative, which I'm privileged to be a member of. Love the roadmap just as a very straightforward printable brochure that just helps teach people this is what's coming and this is what it looks like and this is what you need to prepare. So yes, educate your patients yourself and let the community work for you to help educate your folks. Next slide. Life expectancy in dementia, I think, is also something important for us to understand. I think, so a couple of things here. There was a meta-analysis published in BMJ just earlier this year that looked again at all the data on life expectancy for people with a diagnosis of dementia from the time of diagnosis. And though there was a fairly significant variability by age, in particular age at time of diagnosis, the median life expectancy was about 4 years, and most people lived between 2 and 8 years after diagnosis of dementia. So possibly not a big surprise, but also recognize that that is a life expectancy similar to a lot of advanced cancers, advanced heart failure. Again, life expectancy just across a population really is quite limited in patients with dementia, and therefore we should really be thinking about the benefit of the interventions that we're doing in that context. For a more precise way to understand the life expectancy of your individual patient, I love this e-prognosis calculator. All the e-prognosis calculators were developed by our friends at UCSF. They're really excellent. But this particular one that's linked here will let you enter some facts about your own individual patient and spit you out based on the best available evidence and approximate life expectancy. So again, I think sharing that information with patients is a question of judgment and balance, but understanding it for yourself and thinking about making clinical decisions, I think is really important. Next slide. The other thing I think is important is really understanding where your patient is on, what stage of disease are they in. And so this is just a quick reminder that we think Alzheimer's and related dementias have a number of stages: a preclinical phase where there are really only neuropathologic changes, but not clinical changes. Then a stage of mild cognitive impairment where cognition is impaired, but function remains intact. And then finally, dementia, where there's both cognitive and functional impairment. Dementia itself, sort of mild, moderate, severe, and that's really where we're focusing today. Next slide. I think it's important to understand staging so that you can talk to your patients and inform prognosis. We've all seen patients that progress very slowly, patients that progress very quickly, and understanding the stage and the rate of change, I think really helps us when we're giving guidance to our patients and families. So there are tools available to help you stage your patients. A couple that I love the Dementia Severity Rating Scale, which is a printable form you can give to the care partner to fill out and kind of brings you to a mild, moderate, or severe. The FAST, or functional assessment staging tool, the staging is actually done by the clinician. It's a little more sort of quick and dirty, but both of those are good tools to use. Next slide. So again, I really want to acknowledge here that, talking to patients and families about this stuff, we are trying to strike a challenging balance between providing hope and talking to people about how they can best thrive and remaining realistic about where they are and what's to come. And I may sound a little flippant about it sometimes, but I've lived it and I know that this is not an easy balance to strike. I tip my cap to all of you for trying to strike it. Next slide. Okay, so we're going to take about the next 20 minutes or so to go through a case and sort of go through these concepts that we've talked about. This is Jorge, and Jorge is a bit of a composite of a few different patients that I've cared for over the years. And we're going to walk on the journey with Jorge and his family through mild, moderate, and advanced dementia. So Jorge's 82. He lives with his wife, Connie. He has kids who live nearby and are involved in his care. Jorge has I would say, a fairly typical list of chronic comorbid conditions or multicomplexities. He has coronary disease. He had an MI a few years ago. He's got diabetes, some arthritis, hypertension. He's got CKD3, been stable for a while. He's had colon polyps removed, and he's got COPD. Used to smoke, quit about 5 years ago, and has been hospitalized 3 times in the past year for some flare-ups of some of these chronic conditions. Recently, not quite yet. Recently, because you were perfectly well trained by Echo and in other places, you knew how to make a diagnosis. And so you diagnosed Jorge with dementia, probably a mixed Alzheimer's vascular case. At this time, he's independent in his basic ADLs, but he needs some help with managing his meds. Family's taken over money, needs some help with food prep, and he's recently stopped driving. So you stage him at this point at about a fast stage 4 or a early stage mild dementia. He's forgetful, but he recognizes people and he participates in conversation. And then you look in the chart and you see, oh, there's no advanced directives on file. Next slide. So current state for Jorge, he's on a fairly typical list of meds: aspirin, the statin, beta blocker, metformin, a couple kinds of insulin. He's been on a long-acting and also a short-acting with meals. He's on lisinopril. He's on a few different inhalers for his COPD. Tylenol is needed for his arthritis pain and some vitamins. He also has a fairly typical list of specialists that he's accumulated sort of through the years. He sees sometimes as many as 3 or 4 times a year. He sees cardiology, nephrology, pulmonology, gastroenterology. He sees derm. He had a squamous cell carcinoma removed a few years ago, so they keep a pretty close eye on him. And then he sees ophtho because he had some cataracts taken out, and also he gets his diabetic retinopathy screening. So pretty typical case of an 82-year-old with mild dementia. Go next slide. So what are our priorities as we think about multicomplexity at this stage? Well, like we mentioned, dementia education and support. So helping, especially in early stage, really critical to get the family and Jorge the education that they need around what to expect and how to prepare. If he doesn't have a healthcare proxy or decision maker identified, which we don't see it in the chart, that's really, really important, right? To help him when he's no longer able to make his own decisions. Goals of care, pulse forms, all the advanced care planning stuff that we know are important and we should be doing. And then really to the point of today's talk, starting to have a conversation around assessing the burden versus the value of all his existing treatments, his meds, his tests, his specialist visits. So I've put some words here that I like to use when I'm entering into this talk about, burdens and values, but I would love to hear favorite words that other people have used. So I invite you to just enter in the chat if you have any kind of favorite words to use in these kinds of situations. I use things like, I want to make sure we're focusing our attention on the interventions that will help the most. My goal is to be an advocate for you. I need to understand what you want so that I can advocate. And then I also give a lot of reassurance about walking on the journey together. I'm going to be here. We're going to work on this together. So again, not really emphasizing taking away things as much as emphasizing what we will do, because it's been shown in studies that that's pretty important. Great. And I see Dr. Coulter. What do I need to know about you as a person to give you the best care possible? That's great, Jess. I love that. To the care partner, is there anything you might need right now that we can figure out to help you get through the days? Karen, thank you. I think that nicely emphasizes a very gentle way of making it permissible for a care partner to state what the burdens are, right? Sometimes our patients are very burdened by the healthcare that we just expect them to go out and do. And if we don't acknowledge and open the door to that conversation, they may not feel permission. So that's great. And then, yeah, Carrie, that's great. Like, what's burdensome to you, right? Like, what does that look like? Great, great. Some more good. I asked what you would prefer. We prioritize, right? Great. What does a good day look like for you? Yeah, I love that, Justin. Thank you. Functional and social goals, like what matters, right? That's great. Lot of wisdom in the room. Really appreciate it. Okay, next. So again, what matters most is helping patients identify what matters most. We had a lot of smart comments there about that. And I think that's obviously a big topic all of its own. So I'm not going to do deep dive into that today, but just to point out a couple of principles, these are shared decision-making conversations. So a lot of what I'm talking about today, there's not a right answer. It's really about, how do we give care that's concordant with people's goals and values. I do think it's really important to involve the patient and whoever their decision maker is or will be throughout the course. It's really unfortunate when you have these conversations with the patient and then the patient is no longer able to participate and then you're sort of starting over with the healthcare proxy. So especially early stage dementia, really importantly trying to involve both. It's also important to remember that goals of care do evolve over time. So that's why this sort of can't be a one and done. What people want in early stage of disease and what they want in later stages are not the same. And we need to sort of be there for that evolution. There are a couple of tools that are useful that I, again, highlighted and linked here. The Dementia Directive, developed by our own Dr. Gaster, is a way to allow people to try to write down and state what matters to them as they get more advanced in their dementia. And then the Advanced Directive for Living with Dementia is a legal document in Washington State, a legal advanced directive, again, allows people that the ability to, while they still can participate, to make their wishes known. So those are a couple of really useful tools specifically for folks in situations like Jorge's. Next slide. I did put Jorge's information into ePrognosis just for curiosity. And, given his age, sex, ADL level, physical ability, and some of his chronic diseases. And, it tells us that he has a life expectancy based on, again, best available evidence of about 2.5 years. So, maybe shorter than you might have guessed if you thought, oh, well, here's a guy doing pretty well with just a little mild dementia. Next slide. So here we are, mild stage. You have all this discussion, and Jorge designates Connie, his wife, as his decision maker. You do a post form. He's willing to be hospitalized, but he doesn't want to. He wants to be DNR, and he really wouldn't want to be in the ICU. After some exploration, they note that his insulin regimen has really gotten complicated. He used to be able to do it himself. Now he can't. They can't get somebody there 3 times a day to give him shots. And so you agree together that an A1C goal that his glucose control can be liberalized, and an A1C goal of 8.5 or even 9 is probably reasonable for Jorge. And therefore, you decrease his insulin, and you just decrease him to a once daily long acting insulin, which the family feels like they can still manage. You also see that he's due for follow-up colonoscopy for this history of polyps. And also, he got a letter from the lung cancer screening program about a follow-up CT scan. And they're like, should we do these things? And again, in discussion, you can recommend against further screening, again, consistent with goals and values. And Jorge and his family agree. He has good relationships with his other specialists, and they're not finding that care too burdensome, so you agree to continue all of that. Next slide. So here we are, current state. Our meds haven't changed much, except we removed the short-acting insulin, and our specialists haven't changed much, except we deprescribed to the gastroenterologist since we're not going to do any more testing for colon cancer. Next slide. Time marches on. Jorge has a hospitalization for a COPD flare and pneumonia. Unfortunately, he gets delirium in the hospital, has to be on some meds and needs a sitter. Then after more than a week, he's able to be discharged to a SNF. He's there for a few weeks and then he returns home again. So you come in for the follow-up. They come in for the follow-up, and Connie noted that Jorge requires now some assistance with his bathing and dressing, and he's also sometimes incontinent of his urine. He's still able to walk around, but his balance is more impaired. He's definitely more easily confused now. He doesn't always recognize people like his grandchildren that he doesn't see every day. Connie also says that taking him to doctor visits because of the confusion and the mobility impairment has gotten a lot more challenging, and also sometimes he doesn't want to take his meds anymore. So over several weeks, this fails to improve. So once we're sort of outside the window of the acute delirium, you feel pretty confident that this really is a change in status. And so you can restage Jorge as a moderate stage dementia at this point, about a fast stage 6. So in moderate stage disease, what are our priorities? So again, I think reviewing the stage of the disease, the natural history, kind of explaining we're at a different place, this is the place. Rethinking, especially as he just went through a hospitalization, like, is this still what we want? And then again, assessing the burdens and the benefits, and maybe here in moderate disease, really probing a little bit around the burden and the benefit of specialty care, routine specialty care. And I will often at this point recommend stopping specialty visits for stable conditions. So he's got CAD, he's got CKD, and I often use language like, I can manage that for you, which is true. I manage this all the time, right? I can manage this for you. And again, if you have favorite words that you use in this conversation, please feel free to enter them. I'll also often say, we can always send you back if something changes. So sort of not saying you're never allowed to go see your cardiologist ever again for anything, but really just more starting with, you don't have to do that 3 times a year CAD follow-up visit. And as always, we're sort of continuing our quest for med simplification and thinking about opportunities to deprescribe. Next slide. So you have this talk with them, and Connie's delighted to hear she can stop taking to his specialist every 3 months, and he probably doesn't need the scheduled echo, the full body skin check, the quarterly renal labs, and the dilated eye exam, all of which were scheduled. And by the way, again, that's just a reminder, like, if you do nothing, this is what happens, right? So you kind of have to interrupt that cycle for it not to continue. And let me just be super clear, like, I'm not assigning blame to individuals here. This is really a system level problem. So the family and Jorge want to avoid further hospitalizations, but it's important to them to continue to treat reversible conditions in the home setting. So you update the pulse to reflect those preferences. And you agree to continue all the chronic meds that he's been on, although you look and realize his blood pressure's been running quite low, so you decrease the dose of lisinopril by a lot. Next slide. So now we've got, again, a pretty similar list of meds, although we've made some dose adjustments. But we've deprescribed a number of specialists. And so really now at this point, Jorge's going to be coming to you for sort of routine care. Next slide. Time marches on. A few acute events occur, and now a year has gone by and Jorge's in for his next follow-up visit. Over the last year, he's been pretty stable, except he did have a UTI, which he treated at home, and he also had a fairly significant fall, though fortunately didn't have any fractures. He recovered pretty well both times from those acute events. But his dementia has continued to progress, and now he's spending most of his time in a recliner. He requires 24/7 care and assistance with all of his ADLs. So he needs help now, toileting, bathing, dressing. He only speaks a few words at this point, and he doesn't reliably recognize his children. He's also lost a good bit of weight. Connie asks for suggestions at this visit because it's gotten really hard to give Jorge his meds. He'll either refuse them or he'll spit them out or he'll put them in his cheek or they crush them in applesauce and then he spits out the applesauce. It's just a whole thing. And so she asks, like, do I have to keep giving him all these meds? Like, what's the deal here? You also notice, because you had taken over all the management of the chronic conditions, that he's, your chart is reminding you he's due for all of his routine tests today, his A1C, his CMP, his lipids, maybe his urine microalbumin. It's all coming and reminding you that he's due for all those things. And so you restage Jorge today, thinking about this progression as a severe dementia at this point, probably a fast 7C or thereabouts. Next slide. So here we are now in later stage dementia. And at this point, our priorities, again, reviewing prognosis, natural history, where are we? And then bonus points for talking to the family about the common clinical complications that you can expect in later stage dementia. So we're going to talk about those more in a sec. And then again, I encourage you to enter favorite words for these conversations because these are hard and there's no right answer here. But at this point, I'm really trying to help them think more explicitly about a transition to comfort-focused care. And that could include all of these things or none of them or other things too. But in general, I'm focusing on stopping routine blood draws and tests, sort of the routine management of chronic conditions. I'm thinking at this point about deprescribing all the medicines that he's on that sort of prevent stuff. So the aspirin, the statin, the blood pressure medicines. I'm thinking about whether we might avoid antibiotics for future infections, thinking instead about when an infection arises, might we focus on comfort? And then when appropriate, thinking about hospice referral. And that's where, again, words that I like to use are things like, I want to do everything possible. So I try to use the everything possible in the context of keeping people comfortable rather than the dichotomy we often see of like, do you want us to do everything possible to keep them alive or do you want us to do nothing? People are like, I don't think I want nothing. That sounds bad, right? So I try to bring that everything possible language into, I'm going to do everything possible to keep them comfortable. So yeah, let's see. Any other favorite words for thinking about this conversation? Let's see. Dr. Rubenstein, intensive comfort-focused care, right? Sort of bringing that energy of comfort-focused care is not nothing. In fact, it's a lot. So Karen, caregivers are so variable in how much anticipatory guidance they're able to tolerate. Yeah, very true. Even the planners are often surprised and unprepared for the physical and neuropsych presentations. I witnessed so much potentially preventable crisis management in caregiver support groups. What are some approaches to helping caregivers to be a bit more willing to be more educated about progression? Yeah, ooh, tough question. How do we help people take in information that they need, but which they may not want? And I don't have an easy answer for that, except that relationships and trust matter. So, demonstrating to our patients and their caregivers that we're there for them, that we have that we're working with them, that we have their best interest at heart, lays the groundwork for being able to share important information. And also, I know my fellows have heard us talk about this. I sometimes think about, sometimes all we're doing is we're trying to avoid the next crisis. Like when we have a crisis, we think, oh, I wish I could have avoided this crisis. But maybe the best we can do is from that crisis with our family members and then help it not happen again. Because if we do nothing, the cycle repeats: crisis, 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 crisis. So sometimes forgiving ourselves that we didn't interrupt it, but trying to interrupt it for next time. Next slide, please. So we had this discussion with Connie, and she actually chooses, yeah, I don't want any more blood tests. And oh, we've been doing these glucose finger sticks every day. Can we stop doing those routinely? Yes. Okay. And then, they agree to stop a lot of his regular standing medicines. We decide to continue the once daily insulin because we don't want him to go into a hyperglycemic crisis. That's uncomfortable. We continue the inhalers because breathing matters, and we continue the Tylenol for pain. This family wanted to continue treating infections with antibiotics in the home setting, and they're sort of not sure about hospice, but Connie says she'll think about it. So again, favorite words in just opening the door to talking about hospice. I have a few. I like to say, hospice is a benefit that Jorge is entitled to. He's earned it. And I think he would qualify for it. So I think that's, again, framing the positive of this is something that, you've earned. And also, hospice can be very helpful at keeping Jorge at home and comfortable. Yeah, hospices has a lot of services for caregivers. Great. Again, very positive frame as opposed to like, we're going to stop doing everything. Here's hospice. Good luck. So I think, but the other thing I want to emphasize here is that sometimes I think we have this false dichotomy between this is a patient for whom we're doing everything versus, we're doing a bunch of curative stuff, or this is a patient on hospice. And in fact, of course, these patients, many of them may never choose to be on hospice. And that doesn't mean that we can't approach their care in a palliative way. So really, these are still palliative care patients in every reasonable aspect, even if they never choose hospice services. Next slide. So now Jorge's medications, we've taken off a lot, and we've really only left a few medicines that are sort of more focused on comfort. Depending on the diabetes, you of course could decide to try metformin and not insulin. I think that's, your patient's best, but the principles are the same. And then again, we've removed pretty much all routine specialty care. Next slide. So I just want to take the last couple of minutes to sort of move sideways into the idea of like, what is it gonna look like clinically in late stage advanced dementia? Sort of, how do we know when the end is near, and like what clinical things are gonna happen? Because again, anticipatory guidance with families, I think, is helpful. I just highlight this article from the New England Journal from 2009. I don't know if you call 2009 dated, but it's been a few years since this came out, but it remains one of my favorites, just because they really looked at a number of nursing home residents with advanced dementia in their last 18 months of life, and like what happened to them. And so pulling a couple of points out of this paper. One is that there were clinical conditions that were most predictive of impending mortality, and those were pneumonia, a febrile episode, and an eating problem, which was broadly defined as swallowing difficulties or weight loss or aspiration. And really, I think the point of that, and this comes from the piece, that we should inform families and care providers that infections and eating problems should be expected, and that their occurrence often indicates that the end of life is near. So this is sort of, again, another way of to the people who are open to it, which, as Karen notes, is not everyone, helping them understand sort of what is to come. Next slide. The other nice point the other interesting thing I took from this article is that many of the nursing home residents in this study underwent a burdensome intervention that was of limited clinical utility in their final days or weeks, right? So 40% of them went to the ED or the hospital or got IV fluid or got tube feeds and, all the things that we know and we see. But, and here's the sort of silver lining for me in some ways, was that the people whose healthcare proxies, whose decision makers sort of understood what was up. They knew that the nursing home resident or the patient had less than 6 months to live, and they understood the clinical complications, were actually significantly less likely to undergo one of those interventions in the last 3 months of life, which again, just to suggest that our ability to educate people, it does matter. Next slide. So, in summary, as we manage multicomplexity and dementia, we really need to understand natural history and prognosis and to help our families and patients understand them too. We need to think about stage as we go. We need to be able to explore goals and values, balance the benefits and the burdens of ongoing care so we can interrupt the cycle and give people permission to pull back when that's consistent with their goals. And then really revisit that regularly over time. Next slide. And so really, again, just mostly what we're trying to do here is see the forest, which I really think is one of the primary care superpowers. So that's all I got. Happy to entertain any questions, comments, stories, reflections.
Wonderful. Thank you so much, Dr. Haymon. Just a wealth of wisdom. And we had some great discussion in the chat read out, but I'm sure people have more comments and questions. So opening up the floor.
I definitely enjoyed this and took away a lot of clinical pearls. I especially appreciate the perspective of that this palliative and change in care is not doing nothing. It is more of like an intensive comfort care or what more can we do? Because it just, I think that is the main fear of caregivers and loved ones is that, of course, you want to give more care during these times than less. Yes. And I appreciate that word. The words in this presentation I will carry with me. I definitely appreciate the words of like, let me manage this instead of like, oh, telling them to stop seeing them, but just like saying that I'm going to take on this responsibility. I'm going to support you more and let me manage this. I imagine that can reduce anxiety levels and make patients and their caregivers feel very cared for and supported.
Well, thank you, Julie. That's great. Are you at Kate Weller's clinic?
Oh, excuse me?
Are you at a clinic with, oh no, you're in Cadillac. Okay, sorry.
Yeah.
I was thinking of someone different. Thank you. That was great. And I'm glad that was useful for you. Yeah, it's, I think it's, I don't mean to say it's easy to say, I'm just going to take on all your chronic conditions. Like primary care is hard. And so like that requires like courage and fortitude on our parts. But I do think we do our patients a service when we can do that.
Yeah, I would like to say something. First, thank you very much for going over the stages. I think we haven't talked about the staging and about the FAST as a tool really to assess the functional assessment. And and it's also like hard to talk about the last part, even, really all the stages. But I have a kind of question about what do you think about a patient who are diagnosed with like stage 1 mild dementia, and they're very independent. They live by themselves, but they are like kind of deny it. Or do you think it's important for someone who is diagnosed, especially because they don't have caregiver or they are living by themselves, to kind of I don't know how to call it, comfort them or kind of enforce this diagnosis that they will kind of will be prepared for that, or just leave them in this kind of realm of, oh, I'm still fine and healthy, I don't have any problem?
Yeah, Toby, thank you. That's a great question. In the spirit of echo, I'm actually not going to lead with answering that. I would love to hear, we have a lot of wisdom in this community. I would love to hear other people's thoughts to that very common dilemma of patient says they're fine. How hard do I have to push this?
Exactly. Thank you.
Yeah, I'd love to hear what other people have done or tried.
Yeah, I think that the patient who says I'm fine and doesn't give a lot of information can be somewhat challenged. So I think that the questions about what's important to you, what is, getting them to talk in any length about maybe what is causing them distress, and having them kind of just unpack it a little bit, because the I'm fine response might be just that they don't want to be a burden, or they don't know kind of what is bothering them. So anything that'll just kind of help them unpack a little bit more about what they're seeking or what they do need. Does that sound like it is someone can answer? Yeah.
Great. Any other, I love that. Any other ideas?
I think, of course, dementia, especially the early stage and the mild stage of dementia, people don't know they have a problem. I think sometimes it's not even that they're in denial, but it's because their insight is not there, because everything is still working fine. They can go to grocery and cook and don't. I mean, how dare you saying I'm not doing okay? Or like it's just an natural pushback on like every other thing. But I think that's the time to start looking at other support. If they have a family member that we can engage at that point, maybe that's the time to do that, and use the family members to prepare in a way, like put pause in place, or it's, I mean, not focusing on the disease at this point, but kind of in preparation, getting support from family, or find out where the support will come from and leverage them to start preparing that client.
Yeah, that's
Thank you.
great, Esther. Yeah, thank you. I think, and I see a couple of comments in the chat. I'll read out. Dr. Russo pointing out, even if you feel okay now, you may still need help in the future. We see this often with this condition. I recommend you have a plan for the future just in case, so you're prepared. So sort of, yeah, using that language of like, we should prepare for things. We don't know what's coming. I love that. And then Dr. Coulter noting, I'm fine, right? Fine actually stands for feelings I'm not expressing, right? So people do have feelings when they say they're fine. Yeah, I'll just add a couple of thoughts. One is, remember, and this is part of what makes it hard, lack of insight into one's own deficits is a feature of this illness. The feature, not a bug. So like, people lack insight. Yes, that is part of the disease, and it's part of the brain not being as aware as it once was of sort of what reality is. So that makes it really, really hard. I often will use language, if I'm worried, I'll just say, I'm worried. I'm worried about you. So at least I'm acknowledging my own concerns, so that they hear them. And I sort of say, it's my job to tell you what I'm worried about, and this is what I'm worried about.
Yeah.
And then
sorry.
I'm sorry, just one quick.
I was going to make
thing,
a couple. You made the points about insight and so forth. I notice a lot that they think they're fooling people and they're not. And so like we do when we're screening for, alcohol or substance overuse.
Yeah.
Have other people remark to you that that you're getting a little spacey, or that you're being forgetful, or that you're not able to track the calendar, or pay for dinner or something like that, calculate a tip. Bringing that in of have other people remark to you. And even though the patient might deny it initially, because that's kind of what they're programmed to do, it gives them a way of now viewing their social presentation where people might be saying, I can't believe you forgot this weekly appointment that we always have or something. And like, oh, the doctor mentioned that. And now I'm hearing people say that. And so kind of like trying to bring insight in a little different awareness to them that is noticeable if people start. My husband thought he was faking it for a long time. And finally, some friends started approaching me and I said, look, you're not faking it anymore. They realize something's wrong with your brain. So is there really any point in trying to hide it anymore? And that was persuasive for him to be more honest.
That's great, Karen. Thank you. Really valuable insights. Anyone else? Yeah, the other thing I'll say is that I often try to get permission to build a bridge with a family member or a person, not necessarily about the dementia, but just sort of normalizing. I like to have a healthcare contact for all of my patients, which is true, especially when they're older. And like, is it okay if we just call your daughter and let her know, like, I'm your doctor, I'm looking after your mom. Is there anything you're worried about? Just trying to get permission to build some of that, not even just about the dementia, but sometimes, allowing another conduit for those concerns. And my nurse will often do that, by the way. I'll just say, like, is it okay if my nurse calls your daughter, even if it's not me? Great. Trang.
Thank you so much for the talk. I really appreciate what you expect at the end of life. When you talk about aspiration, more infection, and not being able to eat or swallowing problems. That is so true. So I really appreciate that. Great talk. Thank you. Going back to the question about how do we convince patient, and I get this a lot when patients come in with Valium and said, I've been on it all my life and I never had any problems. You try to prescribe Valium or any kind of benzo or high-risk meds, Ambien. And what I find it works is that your body's changing now. So we've seen that these type of medications can cause a lot of confusion in older adults and increase a lot of increased risk of falls and fractures. And I find that seniors are worried. The two things I worry the most. One is losing their memory, and the other one is falls and fractures. I'm sure they've heard about their friends die from a broken hip or wheelchair bound. They're afraid of that. So I usually tie in losing memory or broken hips, and they if they don't want to change or cut down their medications, at least they're willing to go down on the dose. So oftentimes it works that way. Regarding this patient, at the end of life, or even sometimes, even my dementia, moderate dementia, they're not able to use inhalers effectively. So I usually ask them, okay, I give how often the patients are using the inhalers. And oftentimes I recommend using the nebulizer, switching the inhalers to the inhaled solution so they can use a nebulizer instead.
That is a really great point. Thank you so much. I am next time I give this, I'm definitely making that change to the case because you're totally right. Inhalers aren't the easiest to use, especially multiple. The other thing I've done is, since people are on 3 different individual inhalers, is trying to get the combos so that they're not using as many. Yeah, thank you though. The nebulizer's great point. Great. Any other comments, questions, concerns? Otherwise, I'll turn it back to Sammy and we can wrap up. Okay, over to you, Kimmy or Sammy, however we want to close.
Great. Well, again, thank you so much. That was really great. Yeah, to think through. There's that initial diagnosis, but then continuing to care for people over time and how we really much can shape our care. So thank you for walking us through that. So coming back to, in case anybody missed it at the beginning, again, this is the last weekend to think about this bold grant opportunity. We would love for people to take advantage of this opportunity. The application is due on Monday, and Samantha is available to answer any questions. Please spread the word. We would love to grow our Echo family. Next slide. And yes, I think you've experienced how thinking about a person, a family, it really helps just bring up a richer discussion. We were so lucky to have a case incorporated into today's presentation, but in the future, we would love to hear from all of you. Could be a very general discussion about, inhalers in later stage dementia, little solutions you've had on or questions you'd like to ask the community. And yes, we would like to give out the CME credit. If you're UW faculty, staff, students, text to this number. And otherwise, Samantha will work on giving you that CME credit. And we also have a 1-minute post-session survey. We'd love to hear your feedback. Coming up in July, we have Dr. Sabayan talking about cardiovascular risk and vascular prevention of dementia. And then at the end of the month is Dr. Fisher talking about neuropsychiatric symptoms. And perhaps start thinking about cases that you could bring to the next Echo session at July 11th. And yes, the Bold Grant, as Samantha has put in the chat, is short. And please, we'd love to hear from people. And I think that might be it for today. Thank you again, everybody, for joining, and especially for joining in this rich conversation.